So let's continue talking about the elbow and in particular some of the things related to stability and also orientation of the elbow bones and structures. With relation to this, we'll talk, continuing to talk about the MCL and UCL structures and how might this be affected by different motions. So if you think about a softball pitcher and what that motion looks like, let me pull that up here. You'll notice the mechanics are quite different compared to a baseball pitcher. With the softball pitch, you could see the arm is completely overhead at one point, but that's not the point with maximum velocity, and that's not certainly the release point either. The release point is going to be down at your side. And so when your arm is down at your side, if let's say going from this position to this position is when the most force is applied, the ball is obviously there, and you're going to have a distraction or attraction force throughout the whole arm as it comes down there. It's quite different than the torque produced in this position. And with the softball pitch, the arm is relatively straight. So if the arm is relatively straight, there's definitely less potential for UCL, sprain, or trauma to that area. Whereas with the baseball pitch, there's considerable more UCL, especially depending on the style of pitching as well. But definitely more mechanical compromise with the baseball pitch versus softball pitch. And what about how often softball versus baseball pitchers pitch? With baseball, we know that the velocity is greater, the torque is greater, and along with that, the trauma is also greater, even though the ball weighs slightly less, baseball, compared to a softball. I should say the mass is slightly less with a baseball versus a softball. And with that, baseball pitchers, you probably know, they have to have multiple rest days. Typically, there's a 4 or 5 day rotation. Whereas softball pitchers, they can actually pitch back to back. So the healing time frame is significantly compressed with softball pitchers because it's not as much trauma. Consequently, it's not as much speed for the ball either. So that's a little bit of a trade-off for that. Let's talk about the carrying angle. This is something you've probably noticed. It is sometimes different between males versus females, but this is the angulation that occurs because the medial aspect of the trochlea extends more distally than the lateral aspect does. And that creates this variation right there. So with that, typical carrying angle is around 15 degrees. So if I took the humerus and I went straight down with it, that would be 0 degrees or 180 degrees. And now we're looking at the ulna, and we're looking at what's the position of the ulna relative to the longitudinal line created by the humerus. And that is your typical carrying angle. Now, what are some alternatives to that? Certainly, if you have more of this shape here, where the forearm is significantly laterally displaced from the line of the humerus, we would call this a cubitus valgus. And let me type that in here for you. Okay, my location's a little off, but it should be up there. So a cubital valgus would be typically over 15 degrees. And with here, so what's the opposite? What if instead of going outwards, it goes closer to in line with the humerus? That would be your cubital varus. And these terms, valgus and varus, are going to apply to multiple joints. They seem most pronounced to the elbows and the knees. So you're going to hear cubital valgus for the elbows. And then for the knee, we're going to talk about this later, we're going to talk about the term genu. So there's a genu valgus and a genu varum or varus. So sometimes you'll see varus abbreviate it or written verum as well, but varus is fine. Now this could happen after an injury. You can get a cubital varus after an injury, especially a supracondylar fracture that we're talking about here in a little bit. But let's look at a clinical application of this cubital valgus or varus, because ultimately these are the way the bones are structured, and so we're not going to change if someone has a varus or a valgus at their elbows or their knees to a certain extent because of the bony morphology, but we might modify and adjust some of the exercises around that. And you could try this, you could test this, look in a mirror and test it yourself. So if you stand in front of a mirror, anatomical position, and you bend your elbow and allow it to bend the way it naturally wants to go, does your hand end up on your shoulder? That would be typical, and it might come in to a certain degree. It might come closer to your coracoid versus your acromion or something like that. If you have a more pronounced carrying angle when you stand here, initially when you're standing with your arm straight, it's going to be more laterally displaced. So you're going to have this 20-degree angle away from the line of your humerus. And if you bend that, you're going to notice it's going to go medial because it's going to cross that axis of rotation. And you notice here at the elbow, it's not exactly a horizontal axis of rotation. We're going to consider this a horizontal axis of rotation or an x-axis, but really it's along the orientation of the joint. So just be okay that even though this isn't exactly your flat line, so when you think of x, you probably think of a flat line like that. Because there's a small variation here, we're still going to consider that rotation about an x-axis. So just be okay with that, or sometimes we say horizontal or x-axis. But you'll notice if you do this with a significant carrying angle, it'll come in further. So if you think about this, let's look at how a standard barbell curl will look. So if you have a straight bar and you have an individual with a significant carrying angle, they may feel like their hands are pushed outwards more because they want to bring their hands in here further. But the bar is straight, obviously. It's a 0 degree. It's exactly an x-axis. And it's going to force them outward. So you could see how this might apply more stress, mechanical stress, to the medial aspect of the elbow. Whereas, what about a curl bar? Or sometimes you'll see this, an easy curl bar. So here's Arnold curling that, and with the angulation there, it supports a natural carrying angle. And then even if you look at pronation or putting your palm down, it still supports that natural inclination. So if someone has a very pronounced carrying angle, we're going to want to definitely make sure that we don't use a straight bar with them for those exercises. Oh, let me just delete this off the screen here. Alright, so here's what I mentioned before. If there's some type of fracture, obviously you could see the normal carrying angle. And this depiction is saying for males versus females, it's slightly more pronounced in females versus males, but still under 15 degrees is considered normal. But if you have a male at 14 degrees, that's usually bordering on the abnormal side for a male. You have excessive cubital valgus. In this example, they call it cubulus, but cubital is generally the term we're going to use. And here's your cubital or cubulus varus. What if there was a suprahumeral fracture? What is the name for this deformity? Does anyone know the name for that deformity? That is going to be called a Gunstock deformity. Imagine you're walking and you had a rifle or a gun right there. That's going to produce that gap or that space. So certainly that's something that we're not going to encounter too much from guns. But from a fracture, you might look at someone's elbow afterwards and notice that it's a significant varus coming in this case 15 degrees going opposite of the carrying angle. So that would be called a gunstock deformity. What are the conditions that may result in that? So here's the example: supracondylar humeral fractures. In terms of pediatric, typically 5 to 7-year-olds will develop. This is one of the most common elbow fractures that may occur. One of the ways this happens, as you can imagine, is falling on an outstretched hand. Your fouche injury is how this might happen. And so with that, you certainly have to be cautious afterwards to make sure that the area is immediately splinted and that the patient does not move their elbow until the bone is x-rayed and set. This does tend to happen more commonly with boys than girls, so you should know that it's boys more than girls. And that's the main information for this PowerPoint. We'll see you on the next one. Thanks.